All right, so like I said, I'm going to start off by telling you a little story. Nursing is an amazing profession. I've been a nurse for over 35 years. 20 years I spent at the bedside in a pediatric level 1 trauma center situation. So I'm an ER nurse, and that's what I love. I would do it all day long, except, the hours kill you, and I worked night shift for 20 years. So once my kids were in school and I didn't have to work those crazy shifts, I got a master's in nursing education, and I went to teach. And what I learned when I taught was, wow, this isn't how I practice at all. So I, taught for a while. I was promoted, became working there with Dr. McNamara. I became a program director and then a dean at one of the largest nursing schools in the country. And as I'm trying to incorporate this transition, I realized I didn't have enough information. So I went back to the working sector, and I worked for a company that did nothing but help hospitals start transition to practice programs for new grads to go into practice. So I had this knowledge as a dean of what I thought a nurse should have as a competency when they graduated. And then I took a crazy job as a chief nursing officer for the longest year of my executive life, and realized that all the work I had put into these students did not translate to new graduate practice. And we were burning out our nurses quicker than we could even shake a stick at it. So I thought something's missing. There's a huge gap between these students that I used to teach and these new graduates who are coming to work at the facility I'm in charge of. So I went and, like I said, worked with another company for about 2.5 years doing only transition to practice. And gratefully, I went back to this college, Galen College, and I said to them, I have an idea and you have money, so let's start a company. And we started this Galen Center for Professional Development. And what we did was develop the resources to close the gap between new graduates and practicing nurses. And we have done this for 6 years. So the story really comes to become exciting because there was a little boy who was flown to the United States from Uganda, and he had a heart defect and was coming here to have heart surgery. And unfortunately, the little boy was too sick when he arrived here to have the surgery, and he subsequently died here. So the organization that brought him to the United States flew him back home and discovered that his sister had the same heart defect. And they decided they were going to bring her back, but she was healthier and stronger, and they thought she could withstand the surgery. So fortunately, they did come. They brought the family, and they brought the chief medical officer of a small pediatric hospital from their hometown that couldn't provide their care, along with their chief executive officer, who's a 37-year-old woman who started this hospital because she just wanted to help kids, orphans. So the long and story short of it, they bring this child back. The child has successful surgery. Everyone's getting ready to go back to Uganda, and they run into my chairman of the board of directors for the company that I'm running at the time. And the chief executive officer of the hospital and the chief medical officer, the CEO and the chief medical officer talked to this board director and said, what we need there is education and training. Our nurses just don't have enough education and training. We need help. So without a thought in her head, she called me up, and I got all of our resources that we developed over the last 6 years to the airport, and we flew them to Uganda. So what was very exciting was these nurses just loved these resources. They were so excited. They're sending me emails. And then before I knew it, I was invited to come there to do more training. So knowing that the Galen College would not and couldn't really support that kind of a mission, I started a new company a year ago in February. And it's called the Global Nurse Network because my vision for it is that I can truly connect practicing new nurses in real time with expert nurses around the globe. So I'll tell you how this works. The first visit there, we went in, and this is, think about that community assessment, right? I've never been to Africa, never. Always wanted to go, never been. go there, go into their hospital, and they'd say, we need you to teach us CPR. We have to do CPR 4 times, 5 times a day. My first shift, that proved to be true. We had 4 resuscitations. We didn't get to save any of them. So yes, first day working alongside the nurses, it was real. They need CPR. So I make a plan, I'm going to have these classes, but I am a worker. I need to work alongside nurses, and I need to see what they see. I need to see what their barriers are, what their challenges are. So for the next several days, 7, 8 shifts, all day, all evening, night shift, they have the pediatric early warning system. It's a scoring tool that tells you if your kid is going to get into trouble, and they don't use it. I said, wait a minute, guys, back up. You have this amazing tool that will prevent the need for you to have to do CPR, because you will be able to trend their data and see them getting sicker and sicker. Why don't we pivot and let's do training on this? So we do training on pews, we teach CPR. I'm only there 2.5 weeks. I got to come back to the States. I think, how am I going to continue to serve these people who are saving lives? So I thought, well, I have Zoom. So I connected with the nurses at Whispers, and we would have about every 3 weeks training. They needed training on pews more. They needed head-to-toe assessment training. They needed to learn more about the real science behind CPR. So for the next 6 months, that's what we did. We did Zoom meetings, we did trainings via Zoom, and planned for another trip back. Now, in the meantime, they called me on my phone on WhatsApp, and they would say, we have a kiddo in trouble. Can you help us? With the technology today, they would call on WhatsApp, and on my phone, I have closed circuit TV of every ward in their hospital. So I can look at the child, and I can talk to the nurses live, and we can coach each other. Like, they can tell me what they see, I can tell them what I see. And for example, thinking of culturally sensitive care, I can't tell them you need to put that baby on a ventilator. They don't have ventilators. So I learned while I was in Uganda how to build a CPAP machine from some tubing and some bottles. So that's what I had to do, was coach that team that night through that. So it's an experiential experience. It sounds like, I know that's weird to say, but it's an experiential way to assimilate and accumulate assessment data, is just by working alongside people, seeing what their challenges are and what their barriers are. So throughout the course of those 6 months, we continued training, and we continued to provide support through telehealth in these platforms. So let me pause there. And do you have any comments or questions or anything that's like, what is, I don't know. Do you have anything that you want to just chime in here at this juncture?
Well, I want to know, Bobby, how do you build a CPAP machine out of tubing and bottles?
You got to have some pressurized air, preferably oxygen. But yeah, I can send you some pictures.
That would be wonderful.
So yeah, so what we did from there was I came back a second time. And again, what I mean about this culturally sensitive assessment and learning and collaboration is I get there a second time. Wait, I have to back up. The first time when I started doing assessments, I was like, how are you guys getting these vital signs? Because nobody had a stethoscope and nobody had a watch. And I was like, how are you doing this? And I'm not kidding you. It was a digital clock in every ward. There was only one, and they would set it there. And once the number flipped, they would say, okay, go. And they'd have their hand on their chest because you could feel the baby's heart rate. That's how they were getting it. If they needed a pulse ox, if we were lucky, we had a couple around, but they were few and far between. So during that first visit, I was able to coordinate stethoscopes, watches, all of the equipment they needed to do the assessments. So when I came back, they were equipped. They all had watches, they all had stethoscopes. And so we were implementing and doing the pews together, but I realized this is all great. They have a tool that's a pews assessment form. That's an amazing tool. They have the equipment. They have a stethoscope and a watch. And I go bedside to bedside working with the nurses, and they cannot perform a head to toe assessment at all. So there was another light bulb coming on, is, oh my gosh. But mind you, keep in mind, the first time I walked into the emergency room, which is 5 beds in a small room, on this left side of me, I had about an 8-year-old boy who was in a coma on mannitol without a pump. There's no pumps, mannitol, who had cerebral malaria. I'd never seen cerebral malaria in my life, but I know neuro. Helpful. Had another kiddo with sickle cell who was unconscious and was getting blood transfusions. I had another kid who seemed to be okay, but then I looked to my right and I said, this baby's going to die. What's going on over here? It's a baby who was brought in about 30 minutes prior from another hospital, who stayed in that hospital for 3 days with no assistance, no help, no assessment, no anything, just waiting to be seen by someone. He was in for dehydration, vomiting, diarrhea, and the baby got there so late we could not resuscitate that child. So the things that they were managing, I mean, cerebral malaria, and these kids got better. So I knew this was not hopeless. I've worked with healthcare workers over there, and I will be completely honest with you, don't belong there. They go there for 2 reasons: to see what it's like in a curiosity way, and to come home and say they went there. Those are the wrong reasons to go. So if you want to go to Africa with me, don't say those are your reasons, because you won't come. So, you have to really get the people there and find out what they want and see how you can help them. That's our role. So let's see, where did I trailed off there? Someone help me remember my last train of thought. Testing.
You were talking about the kind of what you had and what you didn't have, and also the that I think these aha moments were occurring that just based on your recognition of being in a culturally sensitive side by side. That's what I was hearing.
Thanks. Well, thank you, because that helps, because that really is the point, is that, we just have to go in there and assess the situation and do what we can with it. But what you realize is you have to pivot. We all have plans. I'm a planner, I'm organized to nobody's business, but when you get in a situation, you cannot be wedded to certain things that work in the United States either, and you've got to keep going backwards until you get to the root of the problem. It's like you've learned in some of your legal classes, root cause analysis. It was kind of like that. We kept going back. CPR, no. Pews, no. Assessment, oh, let's start there. Let's start with assessment. So what we did that second trip is we went bedside to bedside. Every nurse did a head to toe with me. And then I was able to identify 3 really rock star nurses who were able to continue validate everyone on the staff. So we did that the second time. And it was very successful. So the really cool part about this is the science and the research tie-in. You guys have probably taken, hi baby, Felicia, daughter, I'm thinking, maybe.
Yeah, sorry, she is.
That's okay, good for her.
It's getting close to nap time, so she's getting a little cranky.
Good for her, that's all right.
I think part of what I hope you're taking away from this, because you guys are in community, is that just kind of the breadth and depth of what's available and what kinds of things nurses are doing.
So anyways, I was going back to how we pivot to meet the needs of whatever the needs are of the communities we're serving. And so that pivoting helped us. And now, they do these assessments, the head to toe assessments, and we developed a really nice tool to help them document that assessment and all of those kinds of things. So the second time I went back to Uganda, I was able to meet with the Ministry of Health. I was able to meet with the Dean of the Epidemiology Department at Makerere University in Kampala, the capital city, and the Ugandan Nurses and Midwives Council. So we just got the entire healthcare sector represented in a meeting when we got there about what we were doing. And so I said to the team at the university, I said, all the nurses and the doctors over there at Whispers keep saying that they're not having the number of CPR or resuscitations that they've had since we've done these interventions. And that's great. That's great anecdotal reporting. I'm happy to hear it. I believe them. But you know how it is at the end of the day, people want evidence that something really mattered, right? So they volunteered 2 master's students who were studying epidemiology and statistics to go and plow through all of the records at Whispers from 6 months prior to our interventions of training through 6 months out of that training. And we actually have statistical evidence showing improved patient outcomes, unheard of in a program that has not been, say, vetted, right? An interventional program that just kept innovating on the fly to meet the needs and within a different culture, with the knowledge and the skills and the attitudes and the resources that we already are equipped with as what I say expert nurses, people who have those experiences of managing hospitals, developing and delivering educational programs and resources and things like that. So within 1 year and 3 months, we were able to accomplish all of this. And so with that story, we can go back to our course objectives if you want to. Dr. Combs, I'm happy to have you ask me questions or how else I can facilitate some more discussion.
So I love where we're going with this, because really we've talked about in community a lot already about the importance of developing those community partners, those relationships, and really knowing the population that you're working with. I love that you identified those 3 superstar nurses, because that's where we have to go from ground up, right? And build it from the ground up. So I'm going to invite the students to jump in with insights here, because they just recently did another, I'll explain to you, Bobby, they do their first community windshield survey or walking survey.
Cool.
Yes, they do a little area here in Phoenix called Guadalupe, which you may be aware of, that's very, very poverty stricken. And then they do another one, so the class splits, and they do another one in the Sunny Slope area, which is also still considered some impoverished, but not as bad as Guadalupe. So then they actually assess their own community where they live. And so they get to make all these connections. And my hope is that at the end of community 2, after they've done both communities as well as their own, that they really see the value and the importance of knowing where and how to find those resources, which clearly you've done in Africa. So
yeah, but it's more difficult in the United States, and people ask me all the time, why are you doing it in Africa? We have 1 million people that need this here. And that's a great question, and it is because the systems are so difficult to get into. Hospitals have systems in place for education and training that don't include this type of thing. No one is spending money, as you know, on education and training. So I always say I don't go anywhere I'm not asked. So like I wouldn't call up Dr. Combs and say, hey, can I come talk to your class? I don't do that. And I just talk wherever anyone asks me. Or I'll go serve with the Global Nurse Network wherever I'm asked. For example, Armenia, they called us the country of Armenia, right? And they have had a lot of trouble trying to survive the Russians pulling out of their country, because the healthcare kind of went with it for the last 20 years. They've struggled. So, that's what we're looking at are people who are just looking to collaborate on better ways to deliver healthcare. And it's nurses with this COVID-19 and the year of the nurse named by, the World Health Organization. It's ironic and it's a little creepy, but it really is the time for nurses to stand up and say, we are innovators. Nurses at the bedside, I don't know if you guys know this, but on average, a nurse in any unit in any hospital ward, unit, whatever, on average makes 27 workarounds in a shift. And you get in trouble for it, but you're innovators. It's where these crazy, wonderful solutions come from. Is from what you are doing at the bed saying, and you ask yourself, why are we doing this? So, those are tools that'll help you at the bedside, but then in the community, the same thing. We keep trying to solve problems with solutions that have maybe worked in the past, but we're not working in that world right now. We need innovative thinkers in nursing outside of just the healthcare sector in the hospital. We need to be involved with community partners.